So with that, I'll say our wonderful Dean Stefano Bertozzi has been a great leader in helping to support the Right Care Initiative. So thanks for being here, everyone.
Oh, cute.
Thank you, Hattie, and it's a real pleasure. I've only been here 4.5 years, and I know that this is the 10th anniversary, so happy birthday, Right Care Initiative. I realize that if it weren't for Hattie, there probably wouldn't be a Right Care Initiative, so the person that really needs to be thanked is Hattie. So a big, huge round of applause for Hattie. It's great to be able to welcome you here to Berkeley.
Well, somebody's having a stroke.
That was just set up for this meeting.
Yeah.
It's somebody getting to stroke care very quickly. I hope, although sadly the nearby hospital here is no longer providing acute care and will soon be closed down. So this is actually an interesting problem with these consolidation of facilities. If you were unlucky enough to have an event happen up in the north of Berkeley, you'd have to go a very long ways to a hospital that could provide thrombolytics. But that was not the distraction I was supposed to be talking about. So I just want to recognize all the people who are here, the health plans and everybody else who participates, and also recognize the university partners, UCLA that helped to start this with Berkeley, Stanford that has come in as such an important partner, USC that's also participated, and I also want to just thank and recognize the faculty. Steve Shortell is sitting here next to me, who's played an absolutely key role. My colleague Hector Rodriguez will be joining us up here before too long. And I'm just very grateful for the folks who've actually made this whole initiative happen. When I mostly work in global health myself, and I was recently in Mexico and recently in China, and in both cases, the Right Care Initiative happened to come up because we were talking about the importance of actually seeing data and using that to drive performance in health systems. And in Mexico, the example of what extraordinary progress Mexico has made on acute infections, deaths from diarrhea and pneumonia are way, way down, but how little progress has been made at controlling diabetes, which is now the #1 cause of morbidity and mortality. And I was talking about the Right Care Initiative and what it means to bring together organizations that are committed to improving performance on these key indicators. And then when I was in Mexico over Christmas, I was with my mother-in-law, who was 93, and we were up at 11,500 feet, and she had a massive stroke. 2/3 of her right hemisphere knocked out. And because my wife and I are both docs, and because we're very well connected in Mexico, magic happened. We bypassed 3 hospitals to get to the one hospital that would have a neurologist and a scanner and thrombolytics. At 2 hours and 55 minutes, she got a push of a thrombolytic, and she went from a dense hemiplegia with 2/3 of her hemisphere ischemic, an hour and a half later doing this, and 6 days later she knitted a cap for her neurologist to show him how well her left side was working. And most recently, just before I left on my last trip, I was talking to her, and she does have a complaint. A month after a massive stroke, she said, when she's playing bridge, it's a little bit harder to shuffle. And she's still beating me at Words with Friends at 93. So, for me, it was just an interesting 2 things that happened, both in diabetes and stroke front, to make me realize how important this work is. So thank you all for what you're doing. Take care.
So thanks, Steph. I want to add my congratulations to all of us, all of you in the room, for being here. And this is indeed the 10th anniversary. Just going to tell a very quick story about my version of how this got started. And this was, we talked about it a little bit last night, actually about 11 years ago, before the first meeting of the summit. which we held down at UCLA campus. I think it was February, and I was in Chicago for some meetings. I was at the Drake Hotel. Some of you know the Drake, one of the old hotels in Chicago, well known. There was snow on the ground. It was cold. I was about ready to go into a meeting, and I get a call on my cell phone. And it's, hello, Dr. Shortell, very formal at the time. This is Hattie Hanley. And I knew Hattie a little bit, but I couldn't figure out why is she calling me in Chicago out of the blue about 5 minutes before I need to go into this important meeting. And she told me, she said, I've looked at some data, the Department of Managed Healthcare, where she was at the time. This is just really horrific. You're the dean of one of the schools of public health in the state. This is really something we need to do something about. You ought to be doing something about this. And I, want to get something started between you and the colleague school at UCLA. What do you say, basically? Well, one side of me, the left brain rational side said, this is a call out of the blue. Yeah, let's talk about it a little bit further. Let me see the data. What is this all about? But she was so persuasive and urgency in her voice. Can you imagine that? That I said, yes, we're in. Let's do something, and let's talk to my colleague at UCLA, et cetera. Long story short, we did. We had the first summit, got Alan Fremont involved down at RAND, and a bunch of the rest of you who are in the room here today. One thing has led to another, and here we are 10 years later. Hattie Hanley, the unstoppable force. Indeed. So just a few little reminders and maybe a little bit of a template for the day. In the next decade, and I'm just going to stick with diabetes, where we've done more work personally and also personally in my family. My younger brother, type 1 diabetes, unfortunately, from the age of 8 or 9 when he was diagnosed. But in the next decade, it is predicted that we're going to have 40 million people with diabetes. 100 million pre-diabetic, basically ages 40 to 64, that are going to have pre-diabetic kinds of symptoms that are predictive of diabetes. Cost to this country estimated around $500 billion. So it's good to know what we're up against, the challenges, and in my mind, trying to get my mind around all the work that's gone on over the last 10 years, RCI and across the country. There's a couple things in the conference today that I think we should pay attention to. One is the need to really get better at stratifying and getting to know our patients who really need the work and the interventions to make themselves healthier. And we know something about that in terms of those that have multiple comorbidities. They score low on the patient activation measure in the lowest quartile. They often will have mental health conditions. They will, of course, be depressed. They will live in areas where it's difficult to live in terms of the environment and the air quality and access to good foods and so forth. And they will be people who don't have the social support at home. So what do you do about that? So the tools are there to get at that subgroup, but we need to begin to do that on a much more consistent basis up and down the state. That's one thing. Secondly, is what we can do on the provider side in terms of care teams that are really using the evidence that people in this room and others have produced to work with patients as a team in terms of patient engagement, evidence-based care, building partnerships with pharmacists and receptionists who often know some of these patients better than the caregivers directly do, and health coaches and community health workers, and putting all of that to use in terms of implementing on a day-to-day basis what it is we know about the medications and the technologies and the interventions that indeed can work if implemented. And there, I think the major challenge is how do we create what I'll call high reliability practices, high reliability organizations that do this consistently day after day, patient after patient, just as a way of doing business. Yes, some doctors leave, some nurses leave, you have turnover, bad things happen in the world, but you return to this day after day after day. So that consistently over time, we are moving the needle in the direction we need. So we have a great lineup today, and these are a couple of things that I think we should look at, and then when we come together again, get some new insights and ideas to carry forward. So with that, I'm going to turn it over, Hattie, to Dr. who? No, to Hattie again. Thank you for being here.
It is just wonderful to see so many familiar faces, and I would like Janet Wright to come join us up here for this next section of the day. I wanted to take a moment to just thank the sponsors that make this work possible, that make this gathering possible. In particular, I want to welcome a new wonderful member of the Right Care family, Chuck Tennisgetter, who you'll be hearing from shortly, who sponsored the food for today. So with that, thank you so much, Chuck. You'll be hearing about many more wonderful things that he has done, including starting the Stroke Awareness Foundation in just a few minutes. We also want to thank our wonderful members who are sustaining us. Over the years, we have had the help of Boehringer Ingelheim, Genentech, Johnson & Johnson, Novo Nordisk, Ralph's Pharmacies. Thank you, Rebecca, for bringing them on board. And I want to say that we really are a large Right Care family and growing. So we not only have people now gathering from around the country today, with our first Leadership Award winner, Dr. Jerry Penso, who's in the back of the room quietly, always humbly bringing forth his good works. He started our first University of Best Practices with me in San Diego, and he got the bug so bad for quality improvement that he moved to Washington, D.C. to become the Chief Medical Officer of the American Medical Group Association, where he's been spreading best practices for blood pressure and blood sugar and lipid control all over the country now. And he's brought some wonderful medical group leaders from around the country with him today. We also have a very special guest with us, Dr. Janet Wright, who is a cardiologist by training and an earth angel by spirit. She flew in from Washington, D.C. yesterday, as did many of you, and she leads the National Million Hearts program. There are too many earth angels in this room to name, but I'll just say you know who you are and what a wonderful critical mass we have going here today. So I want to introduce you to my mother, Anne McCarroll, here, and my niece, Julia, who never got to know each other because when I was 15, my mother, who had uncontrolled hypertension, died of a sudden stroke. And so I want to impress on everyone the concept that our work has such major echo effects in families. And when we think about the power of this work that we're doing to control these intermediate risk factors, blood pressure control, lipid control, blood sugar control, for some of us it can get a little boring. So I just want to say that the importance of the work could not be greater, because when a family does not have a parent present to bake that next birthday cake, it is absolutely devastating. So the work that you do day in, day out, many blood pressure and cholesterol management heroes in this room. And I have to say, Arne Milstein, would you please stand up? This man, Arne Milstein, has done so many incredible things in his life, including making sure that we have the transparent data along with Steve Shortell that allows us to hold ourselves accountable for our performance, to know how many of our patients are in good control for these critical risk factors. And I remember when I was struggling with looking at this data for the first time when I was working in the director's office of the Department of Managed Healthcare for the state of California, I called 3 people. So it was Steve Shortell was the first call. Arne Milstein was the second. I met Arne with the Pacific Business Group on Health, where he is still Chief Medical Officer. He's also the Chief Medical Officer and the founder of the Clinical Excellence Research Center. But he said, Hattie, if you could just get the medical directors and health systems to understand how to improve blood pressure, they can learn how to do anything after that. But he has been this quiet, amazing voice in the background, helping us to build the Right Care Initiative, and it's had amazing impacts in the 10 years, 11 years since we started formulating this together. So let's just do a hand of applause for Arne. So some of our leaders have been saying, you know, Hattie, you've been doing cardiovascular disease and diabetes for 10 years. Maybe you want to consider doing a few other things. And I just want to say that while there is a great deal of interest in broadening our scope, I believe in the power of focus, and that while this disease management area that we've been working on as a community together for 10 years is not directly about children, it's absolutely about keeping children healthy by keeping their families together. So when Ann McCarroll suddenly stepped out of the picture, who stepped in? My godfather, my great uncle, Admiral William L. Rees, who was an avid swimmer. And he was there for me. He was a bedrock. And he had great medicine at Bethesda Naval Hospital. And so when he was struggling with his own cardiovascular disease issues, I think I was part of the reason he wanted to be there. And he was there. And I have to say, for all of you who are over 50 in the room, and all of you who are over 70 in the room, you rock. You are the people who understand. You have the wisdom to bring about positive change. And almost to a person in this room, and I don't know every single person in this room well, but this is a room of change makers. And I just want you to know that although we're continuing to focus on cardiovascular disease and diabetes, we're also adding the topic of prevention and better management of heart failure, because as we as a community have aged, some of our members have actually been diagnosed with that terrible condition, which we've learned is not being particularly well managed. So we do want to engage you in that. And Janet, would you like to just say a few words to get us started, and then we'll turn to our stroke program. Thank you, everyone.
Thank you, Hattie. And that angel business, you've given birth to a lot of angels. I work with CDC and CMS. It's very tempting, so I'm just going to do it. I'm from the federal government. I'm here to help you. But I am here from Million Hearts. And so Million Hearts is co-led by CDC and CMS, and a really small but mighty team who could not be more excited about what you're doing, what you have done, what you've accomplished, and what you've set your minds to. It is just a real privilege to be in the room with you. I've gotten to reunite with some old friends and gotten to actually meet people that I've heard about for a long time. So I hope that this is the start of a continuing conversation because we need your hands on the tiller of a million hearts. Thank you, Hattie, for the chance to come and join you all.
So as we turn to our stroke panel, I just want to say we are having a few little technical difficulties that have Steve poor Steve is right there in the light. We're going to get some help from our technical staff. He does belong in the light, of course, but it does block that Blue Shield and Blue Cross of Massachusetts have 80% of their patients in good control for blood pressure, whereas in California we're struggling a great deal more. Hector Rodriguez, Professor Hector Rodriguez is going to be going into a great deal more detail, but I wanted to just say that we do now have Kaiser and Sharp Health Plan of California and Dr. Agnihotri. I know I saw you walk in, but I don't see you now. Thank you for, for your extra effort to bring along Sharp Health Plan. Kaiser, thank you for sharing your leadership on blood pressure control over these years. We have some wonderful medical directors in the room who are in this top category. But as you can see, we have a long way to go, and Dr. Rodriguez will be talking with us about how we're organized in California and how we might organize a little differently to do better on these scores. I'm not that good with tech, as everybody can realize, but we want to introduce our stroke panel now. And Steve, I think you and I should probably move away from the light because it's going to, it's really quite blinding up in these two spots here. And so we'll be here, and Arne Milstein, who I introduced a moment ago, will be leading the stroke panel here. Thank you for these wonderful heroes coming together on this.
Thank you, Hattie. This morning we're going to, start out in reverse order. We're going to, instead of focusing on upstream opportunities to modify cardiovascular risk and all of the downstream human and economic consequences that come from missed opportunities to manage that risk, we're going to focus on the ninth inning, acute stroke care. And it's funny, when I ask every year we bring in 6 early career fellows, and we train them in a discipline of how you take a given domain of American healthcare and discover and distill out the 3 biggest missed opportunities to lower the cost of great care. And it really wouldn't matter whether we were asking our fellows to do that or whether we were asking them to disregard costs and optimize health. I think what they tell me at the end of the year would pretty much be the same. They tell me 2 things. They say, number one is, as we've done this for a year, we now realize that over the course of various risks for adverse health, there are certain ambush points that represent the best opportunities in terms of leverage on cost and patient outcome. And so they said one of the things we've learned in the fellowship is the discipline of how you go about identifying those ambush points and the best opportunities at those ambush points to modify the course of both health and health spending in the desired direction. Second thing they say is that our early year exposure to them in a discipline called design thinking, it really makes a difference for them in terms of their motivation and their insight about distilling the right opportunities for any given target that they're after. And part of that design thinking involves spending a lot more time understanding the world of the patients and the clinicians who are receiving the care in the whatever is the target of research. And so we thought we'd model that this morning. And before we get into the the technical, the clinical part of our panel, is ask a patient who's been through American stroke care, Chuck Tennisgetter, to briefly kind of remind us what the patient perspective on this is, and then we'll move on to the technical part of the panel. So this is a quick exposure to a facet of design thinking. Chuck? Okay. Sweet. Should I use this? Should you use? I'll let our.
Sure. While the slides are being placed into the booth, so to speak, why, again, I'm Chuck Tennisgetter, and Hattie very kindly asked me to kick this off this morning from a patient's perspective and kind of an interesting historical perspective. And she asked me to tell you two stories, and I'm going to give you my personal story first and then the follow-up story, which I hope you'll enjoy. And first of all, I'm not a doctor. I'm an MBA, I'm not a PhD, and I'm an MD. I'm not a professional speaker. But this is something that's become very important to me because just as the first speaker talked about his wife, I shouldn't be here right now. Quite frankly, I should be probably under care 24/7, as my mother-in-law was, who had a stroke a year before mine and was in a hospital, did not receive the care that I did, and that led to all kinds of things, which I'll describe in a few minutes. I'm just a businessman. I'm just a person who cares about stroke victims. I'm just a stroke victim advocate, and the foundation we put together does just exactly that, and I'll explain that in just a few minutes. But quickly, my story started at 7,200 feet in our ski resort called Bear Valley in the Sierras, where I was downhill skiing, finished up, had lunch with my family, was going out to cross-country ski, talking to one of my tenants, and I had a stroke. And the stroke was straight down my body. Everything on the right-hand side was gone. I fell over, literally. They saw that, and they brought the search and rescue team in immediately. And the nurse who was head of that team, I'll call her, she is Nurse Kathy, identified the stroke immediately on her part. I had no idea. Now, I've got an MBA from Stanford. I got an engineering degree from Notre Dame. I had no idea what the symptoms of stroke were. Now, does that sound real? But that's the truth, and I find that that is very common. So that's number one thing I want to just stress here for a second. She diagnosed it, and she had, now we're 50 miles from the nearest hospital, 7,200 feet, 5 feet of snow, the 23rd of December, 2000. She called an ambulance, she called a helicopter. They both came. They decided to put me in the helicopter because of the shape that I was in. And literally, I could move nothing on the right-hand side of my body. I couldn't speak. My face was dropped, all those sorts of things that you recognize. Put me in the helicopter. I'll never forget it. I'm lying in the helicopter waiting to take off. The snow is flying. The rotors are spinning. And I can't figure out why this helicopter is not taking off. Come to find out later, Nurse Kathy stood on the runners of that helicopter, would not let that pilot leave until that helicopter was redirected, not to the closest hospital, which was a good one, but could not have taken care of me, but to Sutter-Roseville, which could. Number two. Number three is when I got to Sutter-Roseville, and again, this is 2000, there's no such thing as a certified stroke center in this country. Fortunately, I had a young physician there who had learned about TPA and strokes. And he did all the tests necessary. He looked at me and he said, "You're 55 years old. I can give you what's called TPA. I need a decision in 2 minutes because the time has run out. But here's your odds, 10% chance I didn't pick up everything and you'll die on the table. There's a 30%, this is a plaque clot, and you'll not recover at all. Nothing will happen. And there's a 60% chance that it's a blood clot and I might be able to get you back to some reasonable life." That's number three, the protocol, the TPA. They gave me I decided right then and there, put it in because I didn't want to live like this and I didn't want to live like my mother-in-law had, and then for 7 more years actually. And it worked. I left the hospital the next morning pulling a leg, but I was able to because it was Christmas and let me out. I couldn't speak very well. I couldn't lift, I couldn't write, I couldn't use a fork and a knife, none of those things. And probably So I remember it couldn't really for about 6 months. So this was not an immediate walk out of the hospital kind of a thing. But after going through this, and I have large businesses, at that time I had large businesses with a couple hundred people,